Hello and welcome. Today we're diving into a relatively rare but fascinating condition affecting the eyes called Ankyloblepharon. Specifically, we'll be exploring the instances where the conjunctiva, the delicate membrane lining the eye, is also involved, making it a more complex situation. Join us as we unravel the causes, symptoms, and management strategies for this unique condition. So, what actually causes Ankyloblepharon, especially when the conjunctiva is affected? The etiology is varied. Congenital Ankyloblepharon, present at birth, often arises from incomplete separation of the eyelids during fetal development. In these cases, the conjunctiva can be implicated due to the ongoing inflammation and potential scarring as the eyelids attempt to fully separate. Acquired Ankyloblepharon, developing later in life, is frequently triggered by inflammatory conditions like Stevens-Johnson syndrome, ocular cicatricial pemphigoid, or severe allergic reactions. These conditions lead to inflammation, scarring, and ultimately fusion of the eyelid margins. Trauma, either physical or chemical, can also be a culprit, resulting in similar scarring and adhesion. In rarer instances, severe infections can initiate the process. Let's delve into the pathophysiology. In Ankyloblepharon with conjunctival involvement, the primary problem lies in the abnormal adhesion of the eyelid margins. This fusion often occurs because of damage to the conjunctival epithelium and subsequent inflammation. The inflammatory process leads to the deposition of collagen and the formation of fibrous bands. As the eyelids fuse, the conjunctiva may be drawn into the adhesion, further complicating the condition. The persistent inflammation and scarring can disrupt the normal tear film, leading to dryness, irritation, and potentially corneal damage. The presence of these fibrous adhesions restricts eyelid movement, interfering with blinking and further exacerbating the problem. Now, concerning epidemiology, Ankyloblepharon is considered a rare condition, and precise prevalence data is limited, especially when it comes to instances involving the conjunctiva. Congenital Ankyloblepharon is more common in certain populations, particularly those with limited access to prenatal care. Acquired Ankyloblepharon tends to be associated with the prevalence of the underlying inflammatory conditions, such as Stevens-Johnson syndrome or ocular cicatricial pemphigoid. So, its occurrence is linked to the global distribution and incidence of these triggering diseases. What are the signs and symptoms? These vary depending on the severity and extent of the adhesion. In mild cases, individuals might experience minor discomfort or a feeling of tightness around the eyelids. More severe cases can present with significantly impaired vision, difficulty opening the eyes, chronic irritation, excessive tearing or dryness, and even corneal damage if the fusion is causing persistent abrasion. You might also notice the presence of visible fibrous bands connecting the upper and lower eyelids, sometimes with conjunctival inflammation apparent along the adhesion line. How is Ankyloblepharon diagnosed? Diagnosis primarily relies on a thorough clinical examination. The ophthalmologist will carefully inspect the eyelids and conjunctiva, assessing the extent and nature of the adhesion. A slit lamp examination is crucial to visualize the conjunctiva and cornea in detail, looking for signs of inflammation, scarring, or damage. In some cases, diagnostic imaging, such as anterior segment optical coherence tomography or ASOCT, can be used to evaluate the depth and extent of the adhesion, as well as to assess the involvement of the conjunctiva. A detailed patient history, including any prior inflammatory conditions or trauma, is also essential for determining the underlying cause. While we don't typically categorize Ankyloblepharon into distinct formal types beyond congenital and acquired, we can classify it based on severity. Minimal Ankyloblepharon involves only small, localized adhesions. Moderate Ankyloblepharon presents with more extensive fusion, partially restricting eyelid movement, and severe Ankyloblepharon involves extensive adhesion, significantly limiting eyelid movement and potentially compromising vision. The extent of conjunctival involvement also influences the severity classification, with greater involvement generally correlating with a more severe presentation. Treatment and management depend on the underlying cause and the severity of the adhesion. For congenital cases, surgical lysis, or the cutting of the adhesion, is often required to separate the eyelids. This procedure is usually performed under general anesthesia, especially in infants. In acquired cases, addressing the underlying inflammatory condition is paramount. This may involve the use of topical corticosteroids or other immunosuppressive medications. Surgical lysis is also frequently necessary, but it may be delayed until the inflammation is controlled. Post-operative care includes the use of topical antibiotics and lubricants to prevent infection and promote healing. Amniotic membrane transplantation may be used in some cases to reduce inflammation and promote conjunctival healing after surgery. Unfortunately, there's no definitive way to prevent congenital Ankyloblepharon. However, good prenatal care can potentially minimize the risk of some birth defects. For acquired Ankyloblepharon, Prevention focuses on prompt and effective management of underlying inflammatory conditions. Early diagnosis and treatment of conditions like Stevens-Johnson syndrome and ocular cicatricial pemphigoid can help prevent the progression of inflammation and scarring that can lead to Ankyloblepharon. Protecting the eyes from trauma and chemical exposure is also critical. The prognosis for Ankyloblepharon is generally good, particularly with early diagnosis and appropriate management. Surgical lysis can effectively restore normal eyelid anatomy and function. However, recurrence is possible, especially in acquired cases where the underlying inflammatory condition is not adequately controlled. Ongoing research is focusing on developing more effective anti-inflammatory therapies and surgical techniques to minimize scarring and prevent recurrence. Newer surgical approaches utilizing minimally invasive techniques and advanced materials like biodegradable membranes are also being explored to improve outcomes. In some instances, the use of biological glues is currently being investigated to avoid the need for stitches.